Module 6, Historical and Community Trauma. My name is Dr. Cirecie West-Olatunji, and I have no relevant financial relationships or commercial interests to disclose. This module is accredited and it's approved for 1.5 contact hours under ACPE, Universal Activity Numbers. The official title of this session is The Role of Historical Trauma in the Assessment and Treatment of Patients from Culturally and Socially Marginalized Groups. We have 3 learning objectives. 1, to recognize historical events that impact the lives of patients, particularly those from socially and culturally marginalized groups. And 2, to describe historical trauma and its effect on generations of patients. And 3, demonstrate an understanding of advocacy and social justice with patients who may be experiencing historical trauma. So let's begin by looking at patterns of racial and economic bias in the healthcare delivery system. So first, we know that from research, doctors may be less likely to refer African Americans, for example, for testing. So their perception of what the needs are or how severe the concerns are, the complaints are certainly shaped by personal biases in terms of lived experience. Another study looking at a Boston-based biotech data firm, it looked at billing records that indicated that African Americans with symptoms like cough and fever were less likely to be given one of the scarce coronavirus tests at that time. There are also issues around delays in diagnosis and treatment, and thinking about clients who may have higher rates of diabetes, high blood pressure, kidney disease, leading to more severe cases of COVID-19. I know many of you may have already seen that. And certainly in the state of Louisiana, where we experience disparate rates of all kinds of health issues, they're more disparate for certain communities. Also, when we think about testing sites, initially, there were issues in terms of availability. Where are the sites? Are they in walking distance for many folks coming from low-income communities, where often the majority of the folks do not have vehicles to be able to go through even the drive-through sites? And then also thinking about how equitable is the distribution of medical resources. So thinking really structurally about how the whole system itself is functioning and how that may help or hinder people from vulnerable and underserved communities. Certainly when we look back to the beginnings of the pandemic, the CDC had not been reporting any data on race, and it wasn't until at the local level, at the grassroots level, and through the assistance of advocacy organizations that we start getting this information. Unfortunately, there are still some states that are still not providing us with more detailed information about how people are receiving their services during this pandemic. So all in all, really, there are these issues of subjectivity in the assessment of even patients' symptoms and how we perceive them. So when we think about what are some of the historical contact points that allow us to be able to point to issues of mistrust of the healthcare system, most people can cite the Tuskegee experiment, but rarely do we go back and take a look at exactly what was that. And I know certainly as a researcher, we point to the Tuskegee experiment that allowed us to take a look at ethical concerns when we're engaging in research. And so Here we have a case where there was untreated syphilis amongst Black males, uh, and there was no disclosure whatsoever, and people were they were actually misinformed about what it was that was going on. Also, there are issues around psychological hegemony, the idea that uh, there are mainstream values and that those people who live in the margins in terms of their reality, in terms of their value system, they often have to deal with that in an oppressive kind of way when there are institutional resources that support mainstream values and then step back and do not support these other value systems and realities for other people. Some people might have seen the movie that came out, oh, maybe 10 years ago or so. I think it was an HBO movie about Henrietta Lacks and the use of her cells to engage in medical research. And of course, this created a whole area around ethical and legal concerns around who owns the DNA and so on. So there's that, and people point to that, they talk about that. They may come into your clinic hesitant about taking the COVID vaccine or any other vaccine, thinking about these kinds of issues that have occurred in history. Something that I more recently learned about had to do with the ways in which women's sexuality and reproduction issues have been handled, particularly with Latinx women. In particular, there is a lot of research that has been uncovered about the sterilization of women in Puerto Rico, the experimentation around the first birth control pill that was used. And again, people without their consent, without their knowledge, people were being used as guinea pigs. And so you'll find that people certainly in what we call BIPOC, Black, Indigenous, and people of color, in those communities, people will cite these very real travesties that have occurred historically in their communities. There's also been a revealing about racism in research, how it's conducted, and also gross generalizations about research, even when people of color are not used in the sample. Many people have heard about, for Indigenous, Native American, Native Indian people, the Trail of Tears in the US, and then residential schools in the US and Canada, where children were forcibly taken from their homes and educated in these schools, and where in these government schools, where children where the educators and administrators attempted to eliminate their cultural identity, changing their name, forcing them to speak standard American English, and trying everything they could to erase their cultural identity. Again, people have heard about the internment of Japanese Americans during World War II, and then of course the removal of Mexicans from their homelands. This is just a few things that we know of, and they're mentioned not to necessarily break up these negative things, but for us to have context when people come in and they're distrustful. So I'm going to talk a little bit about the additive effect of continuous trauma and cultural marginalization, how these two things come together and create a multi-layered effect for people of color. So how individuals cope with trauma is dependent upon their social positioning prior to the onset of some traumatic experience, like COVID, like a pandemic. So the pandemic happens not in a vacuum, but it happens on top of what people are dealing with and struggling with in their lives on a regular basis. So when we think about vulnerable individuals, we think about those living in impoverished communities, the elderly, the culturally diverse, certainly, and individuals with mental and physical impairments. And so we think about how they're experiencing COVID based upon historical biases that have occurred. So the current effects of systemic oppression and trauma may be additive. And I show this Venn diagram of COVID, climate change, and systemic racism. So particularly in 2020, a lot of people, regardless of their ethnic or cultural background, were pretty stressed out about observing the civil unrest around police brutality and about people and the events associated with the conflicts that were going on between law enforcement and people in communities and advocates of those communities. Of course, here in Louisiana, we're very aware of the climate crisis because we have been dealing with the increasing rates and severity of the hurricanes that we've had. And then, of course, the pandemic is in the mix there. We're dealing with all three of those things. And again, regardless of your political views, we're still reacting to what it is that we see. So there is this idea of the additive effect. So let's look at these two things of traumatic stress and cultural marginalization. So when we think about cultural marginalization, we look at how there's this limited or lack of access to institutional resources and a lack of power to really control what happens institutionally, right? And it creates a cycle of sociocultural abuse. Also, there's been a lot of research that has come out where we have empirical evidence of the impact of systemic oppression now. So we can take a look at the connection between systemic oppression and high blood pressure, cardiovascular problems, oral health issues, premature labor among pregnant women, low birth weight, and eating problems. When we look at the psychological distress, we add in depression, anxiety, substance abuse issues, and suicidality. And then, of course, we understand that these things occur not in one generation, but they flow from one generation to another. And so what we get is the inculcation or the cultural training, if you will, from generation to generation on how to cope, how to react, how to be resilient or not to these environmental forces. So when we look at the traditional view of trauma, it really is about responding to a specific one-time event in which a person perceives themselves as threatened in some kind of way. So there is responses of fear, terror, helplessness, there's agitated or disorganized behavior, and then we have the hyperarousal, the intrusion, and the emotional shutting down, the constriction. When we think about historical trauma, it's defined as the detrimental psychological outcomes due to continuous, long-term structural oppression on a group of people and their offspring. That's a pretty concise definition that we have in order for us to be able to look at those patients who are coming to us and thinking about not only how they might be responding, but how their children might be responding, as well as their parents, and in some cases, grandparents. Due to a long history of racism and colonialism, BIPOC individuals often express distrust. So based upon their knowledge firsthand or even hearing about it from other people within their family system, it really supports these ideas of not feeling safe, not feeling supported, not trusting people in the healthcare system. And then also you have issues of people demonstrating and exhibiting these signs of stress that we need to take into consideration. System-wide, so I've been talking about healthcare, but I would imagine you're already thinking that you may also see this in education, politics, law enforcement, and judicial systems. So this continuous exposure can compromise an individual's ability to cope with just the normal stressful events in life. And it can put them in a state of constant hyper arousal where they are jittery, they're responding to things in a disproportionate kind of way. And it can impact their immune, cardiovascular, and metabolic systems. So we need to be on the lookout for that. And we also need to ask questions about that as well. When we think about the psychological, which is, of course, my area, we think about how there may be an increase in interpersonal conflicts. Their parenting skills might be compromised. We might see signs of, again, depression, anxiety, suicidal ideation and behaviors, as well as substance abuse. Again, this is really giving us an idea that we should think a little bit broader than that one question that they might have coming in. And we may get a better picture of what's going on and be able to better respond. We certainly saw in the midst of our pandemic that we're in now that it's been documented there's an increase in domestic violence that's going on, and that is not only in terms of couples, but also in terms of parent-child. So transgenerational trauma is trauma that's experienced intergenerationally despite the absence of direct exposure, which we see as traditional trauma. This work, this research, this body of work has been going on since they started studying the survivors of the Holocaust, Jewish survivors of the Holocaust during World War II, looking at the children and grandchildren of these survivors and trying to understand why did they have similar trauma symptoms, even though they did not have direct exposure. Following that, there was a lot of research done on veterans coming back from World War II, the Vietnam War. And then researchers started looking at folks who had not really been in a traditional war environment, but were also experiencing severe trauma symptoms. And so we began looking at Indigenous people, and there's been a lot of research done looking at Native American Indigenous communities and this issue of historical trauma. We're now seeing more research coming out about African Americans and historical trauma. So we really are getting a better idea of what this is, and for practitioners, what it is that we think we need to do. So what is this issue around traumatic stress, and how is it different from post-traumatic stress disorder, for example, or the general understanding of trauma? There certainly are the issues around perception, again, but the contextual factors, the environmental factors, are much bigger when we look at traumatic stress. So ecosystemic experiences, such as systemic oppression, right, are very important and central to understanding a patient's traumatic stress and its impact on their health. We understand that traumatic stress events tend to be negative, sudden, and perceived as uncontrollable. So again, this idea of, taking a look at how have we, certainly in my field of behavioral sciences, how we've moved toward more emphasis on these environmental sources of trauma. But we also need to look at people from a strength-based perspective and talk about ways in which they're coping despite all of these obstacles that exists for them on a daily basis. Sometimes, certainly when I was in private practice, I would marvel at how people would even get to see me because they had to take sometimes 2 or 3 buses to get to me. And they often had their children in tow, little small children. And so I understand it's very difficult to overcome these obstacles. But even despite that, we see people who are, able to cope, and some people are even able to thrive. So it does offer this explanation for differential outcomes. How is it that some people experience these issues? Example of that is Hurricane Katrina. I know when I was deployed in New Orleans to provide mental health counseling, disaster mental health counseling, there were people who were really struggling, trying to overcome their depression and their anxiety. And then there were other people who were already up and at it, who were already cleaning out their homes. And so I began to investigate this issue of transgenerational resilience, asking questions, interviewing people, and finding out that many of the folks who had more coping skills had lived through Hurricane Betsy as young children and were able to observe their parents, members of their community who were able to pick themselves up and begin, getting through and working through. A lot of the people I interviewed who were struggling after Hurricane Katrina were people who had migrated from some of the more rural areas and did not have this experience and exposure. So it's important for us to be able to understand what are the factors that contribute to people's ability to cope. So when we think about this idea of how do we help people, there are several things that we need to consider, and I'm going to give you 4 strategies that you need to use. But I was really excited when I found that there are healthcare professionals who are thinking about social justice in healthcare. Oftentimes, we as practitioners know our field, we know what we're doing, we know how to meet the needs of our patients. But this idea of advocacy and social justice is so nebulous, it's so vague, and we're so afraid that we need to be out, doing some marching in the streets or something in order to advocate for our patients. But it doesn't really have to be that. I mean, certainly if that's who you are, sure. But there are a lot of things that we can do as advocates for our patients. And part of that has to do with thinking about equitable allocation of the vaccine. Certainly, we've done a lot in the US to try to deal with what they call those hot zones or red zones in going into communities and making sure that everybody has the opportunity and to increase the uptake of the vaccine, right? But we also need to think about where do we need to do outreach? How can we engage in outreach? How can we do a better job of reaching out because we're concerned about public safety? And so what is it that we can do? And I know I've had an opportunity to be educated or schooled by pharmacists in Louisiana who talked about steps that they've taken to advocate for community people. And they've indicated that they've been very successful. So it's important for us to take a look and ask that question, what else could I be doing to contribute, rather than waiting for people to come in to my clinic or to my pharmacy? Is there something else that I can do to reach out to people to make sure that there is more equitable allocation and that people have more accurate information in order for them to make a decision? So I encourage you to take a look at some of these policies that have been developed within several health professions that might be helpful to you. So in thinking about frequently asked questions, and I certainly will be very happy to answer any questions you might have specifically about historical and community trauma in the healthcare professions. A lot of people really want to get that elevator speech about how historical trauma differs from post-traumatic stress disorder. And one is really understanding that post-traumatic stress disorder is just that, it's in the past, post-traumatic, whereas historical trauma comes into the present, and it also informs the work that we do in the future and choices that our patients will make in the future. And so it's really important for us to be proactive in assessing and also intervening. Another question is that people often have is, have patients from other socially marginalized groups experienced historical trauma? Absolutely. So this idea of historical trauma, as I said, really the research into it, even though the experiences go far earlier than that, but the research really began with looking at survivors, Jewish survivors of the Holocaust during World War II, right? So there's that. Another is we can look at events in other cultural groups where they've experienced historical trauma. And so we take a look at Irish Americans, for example, when they talk about their famine, for example, that is something that they talk about in the present, and it certainly shapes how they look at the world, their reality, and so on. And so that's important. I would say even people in New Orleans who experienced Hurricane Katrina, even though that's in our recent history, I think that, as I mentioned earlier, given the fact that people survived Hurricane Betsy also back in the 1950s, that it's important for us to take a look at that. I'm not sure when Hurricane Betsy was, but I think it was 1963. So we can take a look at other events that have occurred within other groups that are socially, so not necessarily a cultural group, but a social group. I would say people who experience transgenerational poverty also would have similar symptoms. So we would think about that. So it's not really race-based. And then how has COVID-19 impacted patients who've experienced historical trauma? As I mentioned already, there's an additive effect, so it's multi-layered. So, you know, it's very hard for people to deal with COVID alone, but if there were pre-existing issues such as historical trauma, then we have interaction effects and we have more acute responses to the pandemic. Yes, so please post your questions to the discussion board. I'm more than willing to answer your questions. Continue on in the series to increase your confidence overall. Thank you so much for sitting through this. I appreciate it. Thank you.